Good evening, everyone. So I'm Dr. Mrinal Pahwa. I'm a consultant in urology and renal transplant at Gangaram Hospital, and I'm here on behalf of Conceptual Surgery. So today we'll be talking about various pyeloplastic procedures and surgeries, and in which situation which surgery is indicated. So we'll be discussing about that. So I'll be elaborating on the specific indications of that procedure and what is the methodology and the steps involved in that surgery. So the relevance for this topic is, as we all know, pyeloplasty is done in cases of PUJ obstruction, which is a fairly common disease, a fairly common congenital anomaly associated with kidney. So there are certain, one should be well versed with certain techniques because every patient, it presents a unique clinical scenario and poses a challenge as to do which procedure in which situation, clinical situation. So we'll be talking about those. So pyeloplasty, as we all know, is done for pelvic ureteric junction obstruction. So tracing the history, we have a long history of uh, uh, corrective surgery for PUJ obstruction. It started from Costa and Fingers is a very old procedure, used to be done few years back, but has been given up. But along the way, the various flap techniques came into vogue, and finally in 1949, Anderson and Hines described their procedure, which is now well adapted and followed for PUJ obstruction. So, which is a dismembered type of pyeloplasty, as we'll be studying later on. And down the line, various other flap procedures were also described. So, when we come to indication for pelvic ureteric junction, so first and foremost is if we think the symptoms that the patient is having, they can be easily ascribed to PUJ, and PUJ explains those symptoms, then it becomes an indication for surgery. Secondly, is it's the impairment of overall renal function, which is documented as more than 10% difference in the relative split renal function between the two kidneys. And if we trace the function over a period of time, and if we see that there's a progressive loss of function, then that also becomes a indication for surgery. Other than that, if there are development of stones or recurrent infections or hypertension with obstruction, with documentation of obstruction or nuclear renogram, then also we go for surgery in such situations. So the goals are primarily relief of symptoms, as we have described, and preservation and improvement of renal function. So these two are the main goals of this procedures, pyeloplasty. So the factors that need to be considered before planning a procedure and before defining any before proceeding with any named surgery. So we have to take into account from the various imaging studies that we have, if there are any presence or absence of any crossing vessels, especially aberrant vessels, and if there is any degree of hydronephrosis. I mean, what is the degree of hydronephrosis present in the affected kidney? What is the pelvic size? Whether it's a very box shaped or whether it's a very huge or redundant, and what position is it reaching? Whether it's intrarenal or extrarenal. So we have to look for all this in the imaging studies. Then we have to note the ipsilateral and overall function as the baseline model and as per deciding the indication whether the patient requires a surgery or not. Then if there are any other anomalies that may be present with PUJ obstruction, like there may be a renal agenesis, or there may be presence of horseshoe kidney, or there may be a rotation of the kidney. And secondly, finally, if we need to tackle the stones also, because we won't be doing multiple procedures, so we'll be tackling the stones because of this PUJ obstruction and dealing with the primary pathology in the same setting. So these are the factors that need to be considered, that we need to see beforehand before proceeding with the surgery. So, what are the principles? What are we trying to achieve after a successful procedure? What defines a successful pyeloplasty procedure? What it should look like? So it should be widely patent. There shouldn't be any narrowing or constriction or wasting of at the PU junction. Secondly, it should be watertight, as in there shouldn't be any leak of urine, because if there is a leak, it will lead to urinoma formation, lead to infection, lead to fibrosis and recurrence of the disease. So it has to be a watertight anastomosis. Third is tension free. So that goes for any anastomosis that we do in anywhere in the body. For it to be successful, the two surfaces have to be tension free. Fourth, which is peculiar and specific for pyeloplasty, is the funnel shape transition. As such, there should be a normal, smooth flow of the pelvis into the ureter. There shouldn't be any hooking, kinking, or any additions or any tortuosity. So it should be a smooth passage of pelvis into the ureter. And finally, it should be a dependent drainage. So that there is no pooling of urine in the pelvis itself if the drainage is not dependent or gravity dependent. So we normally do a retrograde pyelogram, RGP, before proceeding with the surgery. In the same sitting, we first do a RGP to identify precisely the position of the UPJ, because sometimes the UPJ, there may be a high insertion of ureter, in which case the UPJ is shifted upwards, or it may be a very lower down because of excessive redundant pelvis. The actual PUJ may be well into the pelvis of the patient. The patient may be having such a dilated system that the PUJ has shifted downwards. So we need to be familiar with the position of UPJ. Secondly, it used to be when open procedures used to be invoked, then it used to help us in the placement of incision. So, and if there's an intrarenal pelvis, we would be preferring a flank incision, a kidney nephrectomy incision. And if it's lower down, then we would be gradually shifting the incision from depending on the level of the PUJ. And also, it gives information about the distal obstruction, whether there is any distal obstruction at the level of vesico-ureteric junction. Because in some 10-15% patients, there is a concomitant VUJ obstruction as well, along with the UPJ. So, doing a RGP confirms all this. So, surgical approaches, it started with open. And in open, there is the standard retroperitoneal approach, which is a flank incision. Then there is an anterior subcostal incision, which is a transabdominal approach. And then there is a posterior lumbotomy, and especially in children and all.